You're welcome.
All right, so we are back with the task force on affordable, accessible healthcare. And we're continuing with a look at the 7 options that we've narrowed, or at least started to narrow down to. So we're going to continue hearing from our consultant. And what are we on at this point, Joshua?
We ended on remote access, and I think we held it over in case there was any further conversation on that. So I guess that's the first place.
I'm going to go to Representative Howden on Zoom. Do you have anything else to say, Lori?
No, thank you. I'm good.
Okay. Anybody else? Okay, I guess we'll just move on. I mean, this is obviously something that we've all worked on quite a bit, so.
Okay, understood. So the next one is extending what we're calling, what we called previously the pre-duals, which is a term of art, right, for folks that are eligible for both Medicare and Medicaid. What we're calling now extending the moderate needs supports. So at the risk of conflating 2 different moderate needs things, I want to just provide a little bit of the backstory on this one. So we do have, as I think everyone in this room knows, a moderate needs group on our waiver today. What we're talking about here is for individuals who are not on our waiver, who are in the commercial market today or market today, and for whom some assistance with activities of daily living would be helpful in stopping them from becoming Medicaid or eligible, having to spend down into Medicaid, and would also help them to stay on their commercial insurance by by providing some services that they don't receive today through their commercial insurance policies, and would also help Medicare in the long term, in some cases in the short term, but in the long term by having individuals maintain their activities of daily living with some mild supports that otherwise would, push them into Medicare and Medicaid eligibility sooner. We know with the aging population in the United States, as well as the additional number of people in the population that we find with disabilities. So we're finding more disabled individuals who are identifying disability in a higher percentage over time amongst our population as we move forward. And so with both that aging population and the higher level of disability within the population identified, that there are more people that need assistance with those activities of daily living, and our insurance packages on the healthcare side, by and large, don't support those activities. Sorry.
I think there's a clarifying question.
Yeah.
Right, when you're referencing people on commercial plans, but if they've turned 65 and they're on Medicare, they're not on commercial plans.
That is correct. That is correct. This is focused on individuals who are between, let's call it between 45 and 64, who are on commercial plans and who are not yet eligible for Medicare, have not spent down into Medicaid, so they're not eligible for Medicaid. They're on commercial plans in our market today, and they still have needs, right? Okay. And those needs are borne today out of pocket for those individuals to support an aide, to support someone to come in and cook or clean, that they can't do, but they're not at a level yet where they're at a financial level where they can support those things. Okay. But at some with some struggle.
No, I get it now. I thought there was a tie-in here to the Medicare cliff that I kept bringing up. So this doesn't address. We don't have that on the list at all.
That is not on in this one.
It's not in this one.
And can you just clarify again? So this is not those who are eligible for Medicare. This is commercial, but again, as we pointed out a number of times, commercial is a small slice of Vermont non-ERISA commercial. So when we take commercial, we're talking about, sometimes we're talking about everyone who's on an ERISA plan or a non-ERISA plan, but so help me understand how you see this
In this one.
in that slice of the world.
So I believe, so there's different ways to implement this, okay? So we can build those out as part of the next phase here, which is what if you do it one way or do it the other. The concept here is that we would go to, that it would be the entire commercial block, okay? That it would be an offering in Vermont to anyone who has that in this area.
Okay, that's
Okay, the way we would be able to fund it and have it be successful is that we would demonstrate, we would go to our federal partner and say, these are individuals for whom a light package of assistance will stop a certain number of them from spending down into Medicaid at all, meaning we'll save the federal government money. We will also save Medicare money because they will delay the need for moving into and spending money in the Medicare space. They'll be healthier when they become Medicare age. That's the right way to say it. Okay. So in both of those instances, we would approach our federal partner and say, we believe, and we'll do the analysis and show it to you, that we're going to save this amount of money, and we're going to take that amount of money and we're going to pay for this benefit. Okay, that's how we fund it. There's certainly state match involved in that exercise, but it makes it much easier to fund what is a light package in the commercial market for things that are not in the commercial market today. The other way to go about doing this is limited to that small individual and small group, where we would actually mandate the requirement to cover a certain package of services in our plans today that we have a jurisdiction over. We could do a combination of those things, right? And so you could do a combination of those two things, and to some degree dependent upon, as always, the funding that we have available for it and how that negotiation with our federal partner goes in getting their funding on it. It's possible, for example, that in the federal conversation, if Vermont was willing to do a longitudinal study that had, as I said, that front-end baseline and showed over 5, 10, 15 years to the federal government that we were staying the course and that we could then demonstrate at that time how many people in our population were better off, because of those things, that we could get some additional funding to support that study itself and the analysis that needs to be done, because it would be a significant benefit, I would argue, to the entire country to be able to see that in a longitudinal way and at a statewide population level. And so we have spoken with Bard and Angela yesterday from Dale, and we're going to continue that conversation as part of this, as part of building this out and sort of getting to how many people does this help and how does it help them exactly? What does the package look like? What's the example of what the package would look like in a couple different iterations as part of this? I want to focus on the who for a second here, right? The who are individuals that are in that, not Medicare yet, haven't spent down into Medicaid, those 45 to 64-year-olds who have some financial strain and some challenges in their lives because they need assistance with some things that their healthcare insurance package doesn't pay for today, further chronic illnesses that as we get older, take a little bit more and a little bit more out of some of us than others, right? And so this is a recognition of that. And it is one that, because of the Choices for Care work that we've done here in Vermont for a long time now, we have an enormous amount of credibility in having this conversation with our federal partner. And we're able to also say that we built the home and community-based networks necessary to support this. First thing, right, that comes when we say that in this group here today is we have a workforce problem across the board. This, so how would we staff for a home aide for more people that are going to get home aides today than have them now? And I would say the majority of these folks have somebody helping them today, right? That's the issue, is that they can't afford to. It's very expensive to continue to afford that, and it's hard to afford it. And some people don't have them helping them. And the first thing out of Bard's mouth on this was, we need to expand the family caregiver supports, because there are families where the family caregiver could keep doing it, but they can't keep taking the time off from work to do it. That's the issue. They're actually the best person to do it. And so that could be built into this program as well. And I recognize, being very close to this, that there's a limit on the willingness and ability for those family caregivers, but that's another issue.
As you're talking, I'm thinking about cases where private insurance may not cover a certain type of illness, for example, consequences of tick-borne illnesses where private insurance won't cover a lot of testing or treatment, and yet it becomes can become chronic. Just a comment. I don't know how we deal with that. How are we going to? I mean, there are two choices there. One is that they become eligible for something state funded, or we change the law with regard to that for private insurance carriers. Anyway.
I agree that those are the choices in that instance. Yeah, I agree. Modeling out the end,
Yes.
how many people and what's the
And who
cost?
benefits. I mean, it's a little confusing and complex because of the way the way things are changing. I mean, and it includes, think about it, it could be inclusive of long-term COVID type.
Well, I was just thinking, I just raised myself a note, long COVID is like, that's an increasing issue that just is not getting the attention it needs.
Yeah, so I mean, this does open up some questions about where we are currently, and also kind of the demographic we're seeing, so.
Yeah, and the package design here
Yeah,
needs to be put in writing, so you
Yeah.
can sort of assess what's in that package, what's out of it, what are the limits of it.
So, yeah, I mean, I guess confusion, concerns about this is, it feels like we're jumping over a group that's more needy and more fits in this entire category of they can't afford the care, they're going to become more ill, and then they're going to lose all their money and end up being Medicaid eligibility when we could stave that off. But we're ignoring them and jumping to a less needy group by skipping, like the 60, 65 to whatever group and going only with the under 65. I don't understand why, because I asked for repeatedly about the Medicare cliff group. And these people are not getting this care, have to spend down in the same way you're describing, spend down to become eligible for Medicaid, and are therefore going to become iller when they get to Medicaid and be at a much higher cost. They fall off a bigger cliff than any of the folks that we're talking about addressing in this program.
Yeah, I misspoke, like to the extent that group of individuals have Medicare and don't have access to an ADL package, we can certainly take a look at that group as well. Yeah.
It would seem to me they'd be the first group to look at rather than going backwards down to younger when we've got an older group that we already know go off a cliff financially and can't get their care anymore because they're now on Medicare.
Yeah.
And they can't access Medicaid in a way they could have accessed Medicaid if they were 64. But they've turned 65, and so they have this massive financial change in terms of eligibility
That's true.
for these supports. So the 64-year-old has much greater ability to quote, become eligible for Medicaid. The 65-year-old all of a sudden does not until they're destitute. So I just think that's a much bigger gap for this same concept.
I appreciate that, Representative Donahue. I don't disagree. So that they should be included in this for sure. Yeah.
Any other questions?
Yeah. Could you say more about, you said working with our federal partners to, save money ultimately in Medicare and Medicaid? What's the vehicle for? Is this a waiver process?
It would be an amendment to the 1115 waiver.
Okay, because maybe I missed that, but that's.
Yeah, it could be an amendment or it could be a separate, states do it different ways. In Vermont, we've tended to put everything into one. And so, that's the direction, to keep the vast majority of things in one waiver, but it could be done as a separate waiver. States have multiple waivers in some states. Some states have one for everything they do, every little thing, and others have, bigger waivers.
So we'd have to see what the state match would be.
Yeah, I think there'd be a couple different pieces of state match, right? There'd be the regular program match for the actual dollars that were being utilized. There could be some enhanced supports, even 100% supports for pieces of the proposal that are innovative and that they want to fund, because of the innovation there that the federal government's very interested in. So that would be obviously something that, the administration would need to negotiate with the federal government. I think that our perspective on it, though, is that this would find welcome with the CMS folks in the discussion that Vermont would want to have on this front. And the question really is, I think, about the design, sort of what's the package, what's the limits of the package, and how many people, the dollars and cents of it, so that is it something that can be done in a narrow enough way to be affordable and still be impactful, right? And that's what that model that we need to work on is going to have to provide some guidance as to what the bounds of those two things are. The reason that we picked up that conversation with Bart and Angela is to make sure that we have a lot of experience in this area about what is helpful and, the differential cost between different services that are provided and the availability of those services.
Okay, good.
So I'm going to ask, I may be the only one, but the names you've used are not names I'm familiar with. So Bart and Angela.
Bart Hill
Thank you.
is, what's his title now?
Is assistant to the commissioner.
Yeah, assistant commissioner. Yeah. And Angela is the head of their adult services division. And her last name escapes me at the moment.
Smith Jane, right? Angela Smith Jane?
Yes.
Yeah, it's hyphenated.
What is it?
Smith Jane. Been in the Senate Health and Welfare Committee number of times.
Okay, it's I don't think I've interacted with them in the same way.
This is the interesting part here, is that we're starting to talk about the intersection between welfare and health. And so when you're talking about being people at home and home services, you move into the welfare side of life. And
Right.
but it is so critical and important, particularly in long-term care, these areas, that it's a substantial amount of prevention services and saving money, keeping things affordable for people at home. I just,
We originally expanded a long time ago when we started to move to HCBS as a way to moderate the cost of skilled nursing facility placements. And we had a whole 20 years of closing beds and resizing the skilled nursing facility space as well as building up the community support so that individuals could age in place. And that was a real win, right? Because consumers prefer to be at home. So, and all of that. Where we are today, because we're pretty far along on that movement here in Vermont versus other states. Some other states, so you know, are at the other end of the spectrum where the vast majority are still in nursing facilities instead of at home. So, you know, good for us, right? Like that we are where we are. But it does put us in a position I think is a good position to be in as we look at the demographic trends facing us to see about how we can start to extend that. And whether that's extension by pushing it into commercial insurance requirements or whether it's extension by providing a waiver that supports those ADLs for individuals in either or perhaps in both instances, we know that it improves affordability and accessibility for people who need supports with their activities daily.
yeah, I mean, it does, and it does bring up a whole lot of other issues that are not related to this particular topic. We'll save those for another time.
You can do those after.
I know.
But I'd like to ask a specific question. Perhaps you know or don't know the answer. It's like what the experience is if other states or other states, you know, I guess it'd be states, have in fact made requirements for commercial carriers to provide this kind of service as part of their plans. Has that been done?
So we have not uncovered that to date, but that doesn't mean that we won't uncover it here.
Okay, but I think it would be, I would be interested to know and just.
It'll be interesting to see what Oregon's, I think they've done some stuff, but it's not necessarily with this group. I don't know.
Oh, so
I'm not suggesting we should, but I just wanted to know what that has ended up looking like.
Yeah, and of course, Washington State is requiring long-term care insurance at the population level as a mandate. So, so that's another route to getting people the services they need through an insurance model. And we can do a page or two on that so that you can see what that looks like.
That would be really helpful.
Yeah, I think it's great.
But that model, the reason we put this forward instead of that is this is more precisely targeted and doesn't run into the employer issues. Someone has to pay for those policies and
Really guaranteed issue? Is there also guaranteed issue?
I don't know all the details
Okay.
on the policy. But
Having been rejected for long-term care insurance 10 years ago.
that's why we'll do the
Yeah.
analysis of the paper on that so that you have.
Yeah, I think that would be because long-term care insurance is really expensive.
Yeah.
But long-term care, look at, we're growing older.
Seen the headline, I don't.
Oh, no, I thought we were all getting younger. Look at this hair.
I just, one other question.
Yeah, go ahead.
Yeah, just, when you say in the write-up, we're talking about the fact that these are folks with incomes too high to qualify for Medicaid, so it requires them to spend down. Just a refresher, because I'm trying to, Medicaid, to be eligible for Medicaid under 65 does not have an asset test, right? It's only after 65 that you have the asset test as well, so you have to lose everything to be eligible.
I'd have to refresh myself as well. I think it's eligible for long-term services. That asset test is in order to become eligible for long-term services and supports on Medicaid, I think.
I think that'd be an important
Yeah.
I actually
distinction.
think it's anybody over 65. Sorry, Joshua. 65 and older, you pass a test.
Great, thanks, Beth. You are correct.
So that goes again to my same issue, concern,
Yes. Understood.
that we're missing the most critically needy group.
So,
So Jennifer Garvey, Legislative Council, I just wanted to flag for the group one other piece. I think it applies both in this proposal and in the, was part of the one where you're talking about adding benefits for, adding state mandates for health insurance benefits. We run into the state deferral issue where there may be a cost to the state because of a new mandate, at least for the individual and small group market, for a new mandate passed in 2012 or after. So anything that was not kind of part of our benchmark benefit plan, and if we didn't rework our benchmark benefit plan and get approval to do that, which I know you're having administration look at for certain benefits, that the state would be required to pay the portion of the premium increase attributable to that new mandate.
That came into play as, particularly as you say, I think as some of us were asking DFR to look at issues of hearing aid coverage.
Right, it started with some interest in hearing aid and there.
It's gotten further, yeah.
Sent them to look at a number of different things.
It's a good reminder that that's a piece.
that's
that-
another, I was gonna say, there's another one that's being studied right now.
It is.
Yeah,
We're
good.
trying to,
Hearing aid, right,
well, it's more than here, it's hearing aids plus.
Hearing aids and others.
right.
Questions? Okay. Anything else here? And so just to, it's your understanding that the federal government would be receptive to this?
Yeah, we believe that they would be receptive to this, and that in order for it to be a successful initiative, they would need to be a partner in funding it, so.
And so are there any modifications that you would make as a result of just our discussion today, or
I think that
we need
have.
more data?
We have some analytics to do on these.
Yeah.
We think that, like, for example, Representative Donahue, like getting the analysis on the over 65 versus the under 65 piece of this and what the package would look like, and if that package would be slightly different depending on that age break, I'm not sure, as in order to meet the needs in that sweet spot. And what the cost of that would be in that area. So that's the next steps in the research. Today, I guess, we'll just be asking for that sort of, yeah, go do that research, or no, don't bother, that type of call on these. And so if as we go through these, you're like, yeah, I don't think so, then and we're happy to take that information and take one off the list, or change it in order to put it in a position where it makes more sense, right? So the next one on here is the cost growth benchmark, and Beth is gonna lead us through that one.
All right, well, can everybody hear me okay?
Yes, we can.
Well, thanks. And I missed last month's task force meeting because my son was getting his appendix out. So I'm happy to be able to be here today and not in the hospital. Anyways, so I'm going to talk to you about the cost growth benchmark. And as Joshua noted in the beginning, when we looked at topics to consider here, we also looked at cost growth affordability, and really this proposal sort of merges those two things. As you probably know, a cost growth benchmark program is a cost containment strategy that limits how much a state's healthcare spending can grow each year. And it's really aimed at slowing that growth so that healthcare can remain affordable for individuals, businesses, and states. And so it's important to note that it doesn't reduce growth in a net way, but it does reduce growth sort of going forward. And so it's sort of like when you're doing, when you're looking at how much you're gonna grow your Medicaid budget every year, right? Like there's still some increase, but this helps you get to a smaller increase in what it is. So you all in Vermont have a cost growth piece as part of your all-payer ACO model agreement with the federal government that limits the growth in that to 3.5%. But you do not have an overall statewide cost growth benchmark. And this really would take, this proposal anyways, would take what you do at the all-payer level and bring it across the state. That would give it some more visibility. And the other piece that we're thinking about here is adding some teeth to it. So other states that have cost growth benchmarks have put into place some ability for there to be either public reporting on payer and provider costs and trends, the potential for there to be some sort of performance improvement plan from providers and payers, as well as Oregon, which just launched their cost growth benchmark in January of this year, has the ability to charge penalties to providers and payers that don't meet the benchmark. So here we're looking to take what you do now, leverage it, and use it as an ability to get more out of a strategy that you already have in place. And you already have in the Green Mountain Care Board, you already have an entity that can help you to implement this cost growth benchmark. And they have some authority here, but their authority has lots of mays in their legislation as opposed to shalls, and giving them, requiring them to do some of this cost growth work and looking to really regulate in a stronger way, I think would give them some more authority and comfort in going forward with some specific initiatives and really help elevate the conversation overall. And I think depending on how you implement this, there would be sort of potential under it for there to be many different things, really hitting on some of the other topics that we didn't, that didn't sort of rise to sort of our top 7. So for example, in order to keep your cost growth low, you could, or the Green Mountain Care Board perhaps could really focus on looking at low value services and reducing the amount of low value services in the state. You could also put in place something that allows for the Green Mountain Care Board to say, look at innovative technologies or best practices that they want the state to really focus on and include sort of potential savings from those practices in considering what the cost growth benchmarks are. There's really ways for this to be an expanded option, or to really be narrow and just put teeth to what you've got today.
Oh, can we ask questions now? Okay. Thank you very much, Beth. That's terrific and helpful. So as you're talking through, obviously, the regulatory piece and the establishing standards for cost for growth would not affect Medicaid. It would be regulated separately.
Well, the cost growth target could include Medicaid overall, although you have your Medicaid is included within your all payer. Is that what you're
asking? How would that okay, so through the all payer, sure, but in terms of having a regulatory body oversee our public program, that's problematic.
Yeah, well, I can tell you in the other states that have cost growth benchmarks, they do look at Medicaid growth when they're looking at overall spending. They do include Medicaid claims as part of their overall benchmark. When they're to set the benchmark and to measure where they are against it.
Yes, I mean, so when we look at inflation and particular medical inflation as a separate inflationary measure, and we look at the infusion of funds into Medicaid or into public programs, for me, I'm thinking that the cost growth standards would certainly fit with hospital rate increases,
Mhm.
and it might fit with private carriers. I'm looking at Nolan, who has his hand up.
If you want Medicaid to control its costs, you can just do it through the budget process.
Right,
It wouldn't need to be regulated. You would make it part of the budget process.
which it is right now.
Yeah.
But
But you would set a goal versus,
right,
what we do now.
but if we're expanding the waiver and at the same time we're saying keep the cost down, then
Build
that,
it in.
yeah, we can still do it.
There's ways to do it. If we wanted to do it, there's ways to figure it out.
Yeah, okay. I just want to be careful because
You could just-
the whole reimbursement issue
Yeah.
and sustainability issue becomes really critical. And when we see more and more people flocking to Medicaid, it becomes problematic but so there's a lot of little questions in there. It doesn't mean this isn't I like the concept of a standard, a growth standard. I know that other states have done it.
Isn't this what we do with the hospital budgets now?
Yeah.
We try
The
to,
Green Mountain Care.
Yeah, exactly.
we
Yeah,
try
it's like
to.
this-
But it's not system-wide, right?
yeah, it's not system-wide, yeah.
So.
It's not system-wide, and there's also no penalty.
Shelter.
Don't need it.
Oh, I'm sorry, say again?
It's not system-wide, and there's also no penalty for not meeting the growth.
Right.
With the
Right,
benchmark.
right.
So,
But just to be clear, a lot of the system-wide ones don't have penalties either, so it's like. some of them are
That's
just a
correct.
matter of
That's correct.
information, so-
right, but I'm just wondering in terms of, does it actually achieve anything? I know a lot are brand new. I think Massachusetts is probably the only one where the question could be asked, but do they have any evidence that their cost growth trend has been lower than other states generally attributable to doing this? Does it actually have a payoff? Do we know if any of these?
Yeah, I think that I have some data that shows that Massachusetts thinks anyways that its spending has gone down because of the cost growth trend. Before it was implemented, the annual per capita growth in the commercial market in Massachusetts consistently exceeded the national trend. And post-implementation, commercial spending in Massachusetts dropped significantly below the national average and remained below the national average between 2013 and 2018. That's when the data is from. And so they estimate that it translated into $7.2 billion in savings. So, it is an estimate though, off of one of the things that's hard is that you're measuring against, you don't know what would happen with cost growth if you didn't have this in place. And so that Massachusetts is maybe a little bit inflated, but they do think that they saved a significant amount of money over that period of time.
And it is helpful in the sense that if you're comparing it to what the trends have been nationally, then that gives it some grounding.
Yeah.
And I would just add to the specifics that Beth has said with some of the thinking as we were talking about what ones to dig in on, that The other ones that we're talking about deal with the very specific who's and what's. This is an overlay on top of those. So it deals with the entire population, the whole $6.5 billion expenditure, and what that should reasonably, what we can afford it to grow at. It puts a target on it, right? It says, let's put a target on this, and let's then think about other things that we would do to slow the growth in that. It is a longer term. You can put it in place quickly, but for it to be successful, you need to see what happened over the last 5 years or 10 years since we put this in, right? So it's not something that's gonna make Josh be like, yay, the legislature did this for me.
Not an immediate bang. Yeah.
Put $10 back in my pocket. Okay.
Sorry, Beth.
I answer my question. Oh, sorry, go ahead, Beth.
I'm good.
Well, I just wondered if there were any states that then, made it translate to the household level, like just said, you can't increase premiums or something more than this much, or how do people feel this? Not the absence of it, but.
Yeah, I think it's hard to translate it to at the household level, specifically on a annual basis. You can do it probably in retrospectively. You could probably look back and show where there were savings, but sort of upfront, I think it's a little bit difficult to make that case. We could try to quantify it that way. The states that have the cost growth benchmark in place, I don't know of any that have done it that way, though.
So we had a fairly significant discussion, I think, early on as one of the potential target items, if you will, around setting an affordability target for households. And I think that's
Affordability standard.
right. What is the standard for what people should pay as opposed to what is the standard of the growth statewide?
Yeah.
Has that kind of dropped out of the thinking, or? Because I think we were all on board with that being really an important thing to try to establish.
I think, and Beth, I know you've done work on this affordability standard side as well, so I'd be interested in your thoughts. But our conversation around affordability standards, we have a tool in place today. We have some experience at this high level cost growth, and so this is something that would build upon what we have in place today at the MCB and be able to push out. We didn't go further on how much the total amount that a house could spend, because there is in the literature, there's a number of different numbers that we could start at, right, and try and figure out, and we could also scale that number based on your income, because the higher your income, the bigger chunk you can spend on. And so we had this exact discussion, right? And the question is, we weren't sure how to make that real as well in the package, right? Like, so how would we, and maybe we have a discussion about that now, how would we take that and make it actionable here? Like, what do we do with that number after we set?
I was just going to say, as you're talking, I go back to a conversation that we had in our committee, and I don't remember what it was. The question was, why does it cost so much, for example, to have a baby? And then the hospital response or the might be, oh, well, we have a financial system that supports people who are lower income, and we go through a whole lot of a financial assessment and reduce the cost for the patient. But we're talking here about just reducing overall costs, period. We're not talking about individual procedures, but then if someone goes in for emergency gallbladder surgery, how do we know that this benchmark isn't pushing down on all of those individual costs? I mean, I think that.
Yeah. I think the idea was that when you talk about actionable, it may not initially be actionable in any way, but at least it gives you something to look at where ultimately you might want to say, if somebody is X% above what we think is affordable, and they had that gallbladder surgery that only, they had this huge additional out of pocket, that's where the state would step in with subsidizing. I mean, you could think in the future of things to do with it, but a lot of our conversation has been around needing to at least have the concept of what do we mean? What do we think affordable means in terms of, that's when I was raising, it's got, your co-pays, your premium and your out-of-pocket costs, or it's not really telling you anything, but like we did with childcare,
Yes.
which is aspirational. So
Yes.
it's aspirational, but if you haven't even defined it, then you can't do anything with it.
Yeah.
Well, okay, so what are you thinking about that? And I saw that I was going to make a comment. It would be helpful to take us out of our quandary.
What I was going to say is that I think you do have some ability to use the cost growth benchmark to tie it to how what kind of rate increases you allow on the commercial insurance side. But you still, when you're thinking about sort of the affordability of premiums and of particular services and what the cost sharing is, it's more than just sort of the setting of the insurance rates. It's also what your employers are paying as part of what their share is. And so it's we'd have to think a little bit more, I think, about how to tie those two things together. You could set an aspirational affordability standard, and I think that's a little bit what the federal government tried to do with the sort of ACA and the sort of 8% out-of-pocket cost sort of as the maximum spend. And so we could think about what what a right level is and sort of measuring against where different households are sort of on that spectrum. But I think we'd have to spend a little bit more time thinking about how to really make that work.
Senator Westman, you want to make a comment?
So, when we started and we talked about and started getting into state, the first option that you laid out, and we talked about Washington State and we talked about Colorado, it really got down into the rates for particular things and the rates that we're talking about in the nitty-gritty. And for me, I tend to think that getting into the rates is a really important thing for us to do if we're really going to get at where we want our priorities set and what the overall cost is in the piece. Instead, really what I see as caps at the top of this is what you're talking about, benchmarks. To do either one of these, and we've seen through Green Mountain Care Board, a lot of resources go in to set those caps at that high level. Granted, it's only a piece of what you're talking about, huge efforts either way with resources, with people, and regulatory processes to get there. And so as I look at this, as I'm starting to march down a track, I'm trying to decide which is the place that I think we could get the biggest bang for our buck for that. And I think it's somewhat looking at the rates. That's just my thinking at this point in understanding this. And I go back to, shame on us in the rates that, that every hospital around the state loses money on a birth. But, when you replace a hip, you make big money.
That's
Yeah, I think there's a lot of agreement around here on that.
Yeah, and I don't disagree at all, but the pitch on the individual affordability, I think just having that aspiration that, you know, why are we trying to reduce costs? And we know there's such vast disparities. If you have an employer who's paying for a platinum plan, or if you're on Medicaid, you've got terrific comprehensive access in most ways to care. But if you've got, you know, if you've got $5,000 or $6,000 or $7,000 out of pocket because your employer, you don't even getting, well, if you're not getting employer, you might be doing pretty well right now on the exchange with the new premium supports. But we've got some people who are paying huge percentage of their income or can't access it. And if we don't even have a concept of, you know what, nobody should be paying more with everything combined, premiums, out of pocket and so forth. We as a state, as a goal, want to ultimately figure out ways so that nobody is paying more than whatever percent on all of their health care. I think that's just really important to have as a guiding mark.
I share that. And I think whether it's considered actionable or not, even if it's aspirational, I think, and even if it's not initially perfected, I think it's something that we should set ourselves to try to set it in motion, to try to see if we can't. Let's wrestle with that.
Yeah, I'm fine with wrestling with that up there, but when I get into the nitty gritty of what it,
But I don't.
if I was to put the regulatory piece in there,
Yeah,
what you're not talking about is creating the bureaucracy. You're really into the policy statement.
But here, if we're looking,
But based on some data.
Yeah, I'm fine, yes.
let's look for a minute at the last paragraph on the third page of the benchmark canvas. And it's what Vermont is doing as a benchmark for the ACO and all payer. So it doesn't, whether the all payer is administered through an ACO or not, the all payer is a model that can be utilized to identify cost benchmarking and to provide increased access while regulating cost and improving quality, because part of the all payer is data collection on clinical treatment. So maybe there's something embedded in what we're already doing that would support benchmarking at different levels. So I agree that somehow we're going to have to regulate the rates associated with the birth versus the knee replacement, but we're doing.
I've been, right, I mean, I've been told by some of the people involved in all payer is that when we truly get there, it achieves that, because I've raised it again and again in terms of, why would you have money-making pieces of your hospital and money-losing pieces? Why aren't things reimbursed for what they actually cost? You know, you have to end up with a balanced budget with your whatever percent growth the Green Mountain Care Board allows. Why are those, and we all know that these price-setting mechanisms in the hospitals are fictions. And so we have this whole fictional system which disadvantages things like parents who want birth, mental health is another one, psychiatric units all lose money.
Right.
That means you lose access to psychiatric care. And yet surgery, hospitals want to build huge new surgery centers. We have an encouragement of that over, for example, physical therapy or other less invasive outcomes.
Birthing centers.
Yeah, so, any rate,
Did we mention birth?
but
We haven't.
just the other reference with that aspirational affordability is one of the things it gives you that's more actionable as a next step is then you can identify what are the subclusters of people who are way off that
Yeah.
aspirational group. And then you can drill down into, is there something we can do about that specific subgroup that targets the greatest need? Once we understand better which of those groups are that are way off from our aspirational cost.
I do think there,
I want to jump in here.
go ahead.
I've been trying to. We're talking about three different things.
Yes.
And we keep talking past each other. We're talking about benchmark at a high level across the whole healthcare spend. Then we're talking about aspirational rate of, or aspirational percentage of household income that there seems to be some interest in terms of trying to establish that, even though it's not an easy reach, but there's real interest in that. And thirdly, we're talking about rates. And when we keep talking past each other on each, we talk about one and then we talk about the other, and we talk about, they're not mutually exclusive. It seems to me they actually fit together. They actually fit together in a very interesting way as a package. And so I want us to not be talking as if one is in exclusion of the others.
No, it's just my
But
comment.
I was gonna say it in a slightly different way, but I agree with you. So the question I have for Beth and Joshua is, how do we resolve the benchmark high level across the systems control, regulation standard with what we're seeing as affordability at the household level? Is there a way to help us see through the forest to the trees?
Well, I agree that these things are not mutually exclusive. And so you could have a statewide cost growth benchmark and at the same time set a statewide affordability standard that takes those that sort of, so that you're looking at things from both sides, both sort of what the overall growth is and what the individual's cost is. And then I think that the sort of rate piece of it is one way to get to both things, meeting both of those other goals. So however you do your sort of, if it's setting specific rates or reducing cost growth in specific rates, or looking at sort of what counts as an excessive rate, say for a birth, for example, I think you could sort of build that into some of the work that that the Green Mountain Care Board or whoever it is that becomes responsible for the cost growth overall looks to in order to control that cost growth. So I think all three things can work together. I don't know, Joshua, if you see anything additional.
So the sentence that I like here is expected outcomes and policy considerations. The growth of healthcare costs to more closely align with wage and income growth so that healthcare can remain affordable for individuals. That for me is the key that we're talking about. And then part of the problem that we experience in our state is that when decisions are made but at the regulatory level, we don't see it's not enforced. It can't be enforced, and it's sometimes just not regulated in the way that one would think it might be. So maybe there's a subtext to this in terms of sending a message about regulation to be more firm.
So
One firmer.
we had some conversation, as you can imagine, about these different things. And this conversation is additive to that, right? So I don't think we have to do one or the other, as Beth said, and I think as others at the committee here have said. The question, to Senator Weston's point is, so what do we do about it, right? I think there's some good things that should be included in a package, whether it's called cost growth benchmark or affordability index or both combined. We set both of those metrics out there and then adjust them over, not letting the perfect be the enemy of the good, right? Like we can set those and they can be changed over time and should be revisited. At the same time, the tools to the regulating body need to be provided, right? And that list of tools also needs to be adjusted over time. So one of the things that we've discussed, and I've spoken to a couple of different stakeholders about this to see what they thought, is that there could be an explicit process, a roadmap process that say occurred over a 3-year period where you task an entity, maybe it's GMCB, maybe it's another entity that gives it to GMCB, I don't know. But with identifying the areas where we have best practices that can reduce costs, right? We go through a bunch of different examples of those, clinical examples, financing examples, all kinds of, every year there's a bunch of those, right? And if I'm Blue Cross or I'm UBM or I'm Dartmouth, I'm running through those on my books every year as part of my process, right? How do I make this more efficient, this more effective? Some of those things fall off for different reasons. At a population level, the state has a different lens on what should be done there than any single actor does, right? So if I'm Copley Hospital or I'm MVP, I have a different lens on what I want to put on that list, right? And I can give you a couple of examples, right? So one example is colonoscopies. They're a big, the rate issue, they make a lot of money in the hospitals, right? They're a big rate winner.
Their #1 income generator.
But as was pointed out to me by a stakeholder this last week, there's a process in Europe, you know, where you can have poop in a box, right? So
Do it here.
Well, we've just recently introduced it.
Yeah, we
Some
know.
people will remember my 15 years ago, my floor speech on scoop the poop versus the money we were putting into colonoscopies and the French study on that.
So, but it's widespread now, right?
Yes.
It could be widespread here, but my point there is not,
Yes. Caught up. Right.
my point there is really to just point out that when we put one of that on the table, it helps insurers get by reducing insurer costs, right? And it hurts hospitals by taking dollars out of a lucrative area when you move in that direction. The best processes put a number of different issues of those things on the table that sort of hurt everybody equally in that exercise, right? When you get to the actual, these are going to go into rates. And there needs to be a process for putting those things on the table, a stakeholder process that, happens and provides that visibility so you can plan for it. So one of the other big problems with regulatory using the hammer is if it doesn't have that process in the beginning you can see daylight. So in other words, you discuss it in year 1, you implement it in year 2, you adjust rates in year 3. You don't adjust rates in year 1, tell them what to do in year 2, and then hope they actually survive it in year 3, right? And so we can set up, the legislature can set up that type of process, and you have an institution in GMCB that could implement that process, right? You could also do it in other ways. In concert with the cost growth benchmark and an affordability index, you have a reason to do it, right? Like those are, so we're trying to do this, like get everybody's affordability index to here. In order to do that, we know we need to bend the cost curve, and we know we need actual tools to do it, right? And so that type of specific establishment of process would be helpful. And some adjustments to the current laws and regulations around GMCB can help us move in that direction for all of these things. So what I would take back from this and is add an affordability index to this cost growth benchmark and give us some real things we can do, process-wise and specific-wise, to change the trajectory, right?
Well,
On rates.
well, yeah, well, on rates, I just say my initial reaction is whoever sets the high level number, I shouldn't be dealing with the rates, but in that overall process in what you're talking about, there's a cost to building these systems to do that. And, with my appropriations hat on, with all of the push me and pull you to get to I want to be as efficient as I can, and I want to understand that over time, what are the steps we can do that are actionable with the money that we have and resources that we need to set. And that's partly why I think this is a really good discussion in the overall to have, because I agree with you, it's not either or, but it doesn't do any of us any good if we can't figure out a way to build the systems to do that.
And which segues directly to just like the whole problem with the all-payer model was, were we going to achieve savings that would outweigh the bureaucracy that was being created, a brand new one? And are we now even thinking and talking about yet more bureaucratic oversight expansion? And where does that interplay with all the money we're putting into bureaucratic oversight in the all-payer model? And how do we make sure we're not, building two empires that cost a ton of money without actually producing the payoff that we're hoping for?
Or another way to look at it is to ensure that the regulatory body that we do have has the tools to do what it needs to do. And so, because I have a sense that we're really resourcing the board adequately. But the question is, do they have the policies in place that they need to make decisions? And then what relationship do they have with the ACO and the all-payer?
Well,
So those are things that we talk about a
well,
lot.
I'm a little, if you load everything into one place with, for example, like the Green Mountain Care Board, and if you load all of this into one place, is it as effective as if you have rates set maybe here, the overall number that they've got to rate somebody set over it, and you spread this out instead of having one specific place doing everything?
Well, I think about the PUC and the role it plays. And so, I think if you spread it out, then you've got a decision over here that's slightly different from what might inform this decision. Yeah.
I'm just
It's just like,
I'm asking a question.
Yeah, no, it's a good question. When I
I'm
wrestle
asking-
with all the time.
If you have a number that's set, that's the overall at the top, is it better to who have someone that has regulatory experience, maybe at banking and insurance, deal with the rates? I'm just asking the question, is that a better model than all in one? I do like the model of the Public Service Department and
Yeah.
the PUC. They've been effective. How do we replicate that effectiveness?
Exactly.
Yeah, I just worried that more places means more risk of duplication, of overlapping what they're
Well,
doing.
those
and
decisions have to
costing
be
more.
made. They're subsequent to this.
Yeah.
Yeah, but I
No.
just think,
Well, they're correlated.
Well, and I'm sitting here thinking, it's easy. I mean, it's not easy. one person's regulation is another person's, you're messing with me.
Yes.
It's like, and so, part of our role, as I see it as legislators, is to try to think where the policy should be
Mhm,
at the mega level.
mhm.
Because in fact, rather than as an advocate for any particular specific entity or piece of a system, and we get back and forth, we fall into those traps at times, but really the challenge to us around accessibility and affordability is to look at it at the broadest level, to try to bring it down to impact people at the personal level. But to do that, we have to have policy. What we do is primarily set policy.
Well, you know, if the CPI for healthcare cost was comparable with the other CPI, the real one, maybe we wouldn't have the problem that we have. Is there a way that you could bring us some information that would integrate?
From the PUC, like that, the question about how the PUC does it versus.
No. I'm talking about integrate the cost growth benchmark with the household affordability question.
Yep, I think we can.
We don't want to get in at this point into the regulatory system needed to do it, but that's something that would, this is a long-term, short-term, medium-term, long-term. We're talking a lot about the long-term needs.
Yeah, I think there's several things we can do here between now and the next meeting, including bringing this together in, again, a white paper, I think would be helpful, like just not an extensive thing, just a couple of pages that explains what the specific changes to GMCB would be that would help facilitate this, right? Like from a policy perspective, and the difference between doing the cost growth benchmark and the affordability index, and to Senator Weston's point, do all those things belong in one place or not? We can take a look at how other states have done that and located it differentially, and some of the models that they've used to do that. So I think that's all in bounds for us to provide that additional information and to move this conversation along, as well as part of that, identifying the range of benchmarking that's been done. So, you know, and how would we go about setting such a benchmark here, and what's the likely outcome of that exercise, right? Without actually doing it, I think we could provide the balance for what the likely outcome of that is, and the same thing with the affordability index.
I see Nolan, and then I have something I want to.
If I may, like
For the mix.
the conversation around the regulatory conversation, we have another consultant looking at that. So I would say I don't know how much, unless we have our consultants talk to each other, which I don't think we're there. Just wanted to sort of raise it. We have another consultant on behalf of ATRUC looking at the regulatory structure and Green Care Board. So I just wanted to just remind folks of that, you know, have two consultants doing the same work.
So if you just tell us where our lane ends, then we'll say that.
Yeah. That's what this was.
But, so can the other consultant is looking at what we're doing now.
Is looking at what we're doing.
And what we're discussing here is an expansion.
No, what I think what Josh was talking about here is, the way I see it is you're talking about cost growth benchmark, for instance. The Green Care Board's a tool to do it. The different proposal. We're talking about either like policy or the tools we have to sharpen. You're talking about sharpening the tool to make this proposal more.
Well, you are there, but if we got into talking about specific rates.
We're not there yet.
Well, I thought that was at least a piece of our discussion.
Okay. I didn't know we
You
were,
mean rate setting itself? I mean, the board does have the authority to set rates, but they haven't exercised that authority and it's still within DFR. So, I mean.
if we're talking about requiring the agreement on care board to do something, yes, that's within our scope.
Yeah.
I'm saying, if we're talking about, you know, like you were talking before, like breaking up the agreement on care board and putting stuff over here versus over there, then that's.
I didn't think that's what we were talking
I
about.
I don't think anybody has said anything about breaking up the agreement.
Not breaking up the care board, you were talking about how this group doing this piece and this organization doing this piece and the continuity, and then the PUC versus so that kind of does get in the regulatory. So I'm not saying do or don't, I'm just sort of reminding folks.
Right.
I mean, there's other work over here, so we should be mindful that we don't have two consultants doing overlap.
So maybe it would
That's all I was
be
getting.
helpful to have you bring the two consultants together to figure out where they are or not. Does that work or however you think that should happen?
I'll talk to Joshua after this.
Yeah.
In the sense of, but that's necessary. I wasn't telling you what you should do, I was just reminding folks.
No, but we don't want to step into the other work that's going on. As we said before, we want to, make sure that we're consistent and collaborative, but
Oh,
okay. Well, this has been an exciting discussion.
I'm not sure if this, well, let's bring this to.
Let's bring this to
I think
closure.
we're at that place.
Yeah.
Yeah, okay. I want to just share that, I mean, we were asking, or I was asking earlier in particular about the federal premiums and what it saved Vermonters, et cetera. And I have an email because others are listening. And Sean Sheehan from DEVA has shared an email that, or from Devin, sent to Devin Green, who was also listening, has shared it that the Vermonters who have availed themselves of this have saved an average of $186 per person per month. And that is significantly more than the national average that's being saved with those additional subsidies. Now, I don't want to substitute that for getting more information that we can understand more fully, but that goes to my point earlier of the direct line of actually making a difference of $186 a month. That makes a big difference in people's lives. So I think, again, I want us to come back to actually have that information in hand as we think about other longer term and more immediate impacts, because I think we'd be foolish not to understand what's really happening right now. And I would say as well, because the open enrollment period is starting again, to make sure that every Vermonter who's eligible for this is actually being able to avail themselves of it. Because that is also one of the issues of even knowing, because of what's been described to our committee at times by, Jessica Holmes, who's a healthcare economist, the stickiness of not changing your health plan, because it's just it feels so complicated. It feels so hard to actually even take it on, that people tend not to make the change. In this case, if they don't make the change, they don't avail themselves of significant savings that they may not even fully appreciate the impact it would have on their personal lives on a day-to-day basis.
So maybe it would be helpful for folks who are listening, who have the capacity to get that message out. That would be extremely helpful.
Yeah, I mean, frankly, I've been concerned about the promotion of that. I see ads on television for New York State. Be sure you're doing this. I'm thinking, I'd like to see an ad that says, Vermonters, make sure you're doing this, or whatever.
Anyway, we're moving adrift.
Well, we're
But
moving
it's
adrift, but I
not
think
adrift, but they saved $186 per individual. So I'm glad they sent you that email. I think we should move on
Federal money.
because we have 1 hour left.
Okay. So the next one is expanding the Vermont Blueprint for Health.
Yay.
So, I think we all know what the Vermont Blueprint for Health is today. And
I think most people don't, to be quite honest. I think most people, if they were listening on the street, would have no idea what we're talking about. I think that's one of the, I mean, it's important for us to understand that as well.
well, let's talk about the Blueprint for Health for a moment then, right? The Blueprint for Health was started in the early 2000s, and in pilot communities and then expanded statewide. In order to support, it's an all-payer initiative, so it's paid for, all payers contribute, including Medicare, to the support of the staff that are support, and those staff support at the community level primary care practices, that are patient-centered medical homes, to provide their community health team support, so multidisciplinary. In some communities, those are mental health professionals or a care coordinator. It depends what the community needs, who's on that team from a technical training perspective, but they then support that community and on a referral basis. So those primary care medical home folks can refer individuals into that community health team, and that community health team helps make sure that they're directed to or directly receive supports that they need to coordinate their care and receive the services that they need to receive. So we know, so let's pat Vermont on the back here, right? Like Blueprint for Health is widely reported and been presented and replicated in other states, and is seen as a success from a national perspective as a great way to do community care and to support those primary care physicians in both improving their practices and stepping up the ladder of primary care medical home, and also in helping the patients receive all the care that they need in their community. So we see when we talked about the Blueprint for Health, and alongside the all-payer model and the ACO and the global commitment and all of the things that Vermont has done, it's one of those things that Vermont has done very well. And we see it as an equity instrument, as in that anyone can be referred, regardless of payer or no payer at all, to those community health teams, and those community health teams help all comers who are referred to them. And so we have an engine in the local communities for doing things to support individuals to connect to care and to help primary care physicians. So think of it in a bunch of different ways, right? Not only are those community care teams there helping the individuals, every time they take a referral and help that individual, it takes time, it gives time back to the physician who otherwise would be trying to figure out how to help them without that support. And when we think about workforce, one of the things we can do to help our primary care workforce is to take the things that are not directly in their wheelhouse yet they're dealing with and give them supports to continue to deal with it. And so we purposefully are not prescriptive here in saying the blueprint we should add X amount of staff or this type of staff or in this geographic region. I think that program design belongs at a different point in this process. I also think that there's something that's pretty important to do on the front end to support the blueprint that hasn't been done before. And I talked about it a little bit earlier, and that is to provide the identification and stratification. In other words, to identify not just by referral, but to do a population level identification of people that have needs in the community that are unmet, and to then make those referrals using that identification and stratification. Your BCCI team, so that's team at Medicaid that's managing the top couple percent of complex individuals, uses a stratification engine. Your ACO uses a stratification engine, UVM does, Dartmouth does, Blue Cross does, MVP does, all of those players in the field have their own care management and care coordination. They're following specific individuals for specific reasons. And all of them are identifying people who are at risk and need that type of supports. The blueprint doesn't use that methodology today. It's a pure referral based. So we believe that we don't have to actually be additive. You're already paying for multiple ID and stratification here. What we need to do is to think about how we do that stratification for all Vermont residents. How do we do that for everybody? And without spending more money, like how do we combine that and do it for everybody? And how do we allow, there's a couple different ways. I'll just say a couple different ways. One is you could have a vendor hired to do it for the entire population. And they could take the requirements from your different organizations that want their own, that have their own care management and give them back the fees, right? They could do the same work under one umbrella instead of under multiple separate contracts. Now, if I'm any one of those entities I mentioned, I'm not gonna like that. I wanna own it. I want it to be mine. I don't wanna give someone else my secret sauce, all of that stuff. Got it. That's why I said that's one way to do it, right? Another way is to give the blueprint its own engine, let them do it themselves, right? Now we gotta pay for that contract, right? To everybody's point, to appropriations point, we need another however much to do that. We could build it into the ACO. The ACO's got one, so that maybe we get a single partner to help us with it, right? And we still have to write a check to do it for the blueprint, but it's a smaller check because they don't have to hire their own vendor. They're just a scope of work under one vendor. So, and I'm sure that the administration and others will need to weigh in on how to do that. And again, I don't want to be prescriptive about it. What I want to point out is that we believe the blueprint should have that tool available to them that would allow us to direct the need. And not only should they have it available to them, we need to have insight to be really effective at the people that Blue Cross is already managing and doesn't want in the blueprint team because they're already managing them. That we need to be exclusionary in order to be helpful in some instances with that predictive modeling. It's different from referral because referral is the physician says, I need help with this patient, they should still get referred, right? But from a expanding the blueprint and using some of the same tools that others use, we believe that that could be very valuable, but we do have to figure out how to not step on everybody else's toes as we do it.
Tease out what's
well-
already being done and not try to do it again.
That's right, and that's, I think, your first sentence in that paragraph, before you get to the data and the risk stratification. I think one of our big problems now is we have all these multiple groups doing similar things for some of the same people or the same things. And you identify the payers have their own care management. The ACO is supposed to be all about saving money through care management. Providers are involved in it. DIVA has its own care management for high-risk individuals. And Blueprint addresses some of that. And I think unless that's coordinated, we just keep throwing more money at care management that's not well integrated as when we're supposed to be doing population health management. And part of it is that the ACO, as we know, won't meet its goals unless it really has a significant part of the population, which it doesn't have yet. So we're doing a lot of duplication of infrastructure to do all these things. The insurers are not giving up all of the care management they do to have the ACOs do it. Neither is DIVA and so on and so forth. So I think it's a huge need. I don't worry about doing more with the blueprint. I think it's an excellent model to work with. But to the extent that it expands another player in this very split out concept of care management is what works best, so 10 people are going to do separate care management is contrary to the concept.
Agreed. I think that what we wanted to point out was that we think the blueprint is an equity model as opposed to the others, which are not.
Yes.
And it is locally integrated as opposed to the others, which are not with multidisciplinary teams at the local level, and already engaged with our primary care medical homes throughout the state. So.
But you're saying to the
think that-
exclusion of them, and I'd say get rid of the others.
Well,
Good luck with that.
Yes, to the exclusion, what we want to do is to make sure that the right people are assigned to the Blueprint for Health.
Right.
And it may be that if Blue Cross, for example, or MVP, for example, our insurers had faith that the blueprint assignment and had visibility into the return on investment from that blueprint assignment of their folks, would be thrilled to start doing those analytics and pushing people to the blueprint. But absent knowing that, which they don't have that information coming out in a data stream that shows ROI that they would take to their board
Right.
for the blueprint, absent that, they're not gonna give up their Johnny's gonna go to their care management, not to the blueprints, because
Right.
their care management, they have that data on. And so I think one way to help the blueprint is to actually help them get that data on their, or require them to get the data on their population to feed these are the blueprint people we've helped. These are the MVP people. Like, let's do it by payer. Let's do it let's give them that information so that they want to help get people into the blueprint.
So is this in a way because in fact, that's what the all-payer model was supposed to be. It was any willing provide, like get everybody on board by enticing them, not forcing them, because they're going to see that return on investment of having a population-based care management through the ACO.
Yeah.
That's not happening. I mean, that's the big piece that hasn't happened yet. People they're not signing on, they're not signing their folks on because they haven't seen success yet you can't see success without enough people being signed on. And that's where it's kind of stuck. And I think, I agree that the blueprint is a great model to do exactly that. But if we still continue to have people not signing up, if we still keep having these disparate systems, I don't know how we help make movement overall.
Sorry, go ahead.
No, so I was just gonna say, because I'm the consultant, I can say this, that willing approach, which we can incrementally try and provide some data to help get that willing approach. At some point, we don't have to have it be a willing approach. Like, so we could require the use of the blueprint in stronger in our regulatory framework. That is an option for us.
Does that replace the all-payer model then, in a sense? Because that's their tool for cost containment that it's premised on.
So I think there's been discussions about where the blueprint staff belong and who manages them. Originally, they were in the health department. They were moved over to human services years ago. And again, don't want to step on the administration's toes on where things should be located so that they're most effective. What I would say is that the team itself is the right team to be expanded in order to improve equity, make sure that we're supporting our primary care physicians and all of that. How we do it and whether it I'm not convinced that the blueprint team should be in the part of the ACO, right? Like, I'm not convinced that that's effective.
Can I say
right?
something? When the blueprint was originally established, it was established as a model of care. So the healthcare team, and then a model for collecting data for doing clinical evaluation, a population-based evaluation. And it has become a thing. It's no longer a model, and yet we see private carriers emulating the blueprint and collecting data and doing the same type of analysis, but keeping that separate. So the goal is to align the alignment's the question. How do you make that happen? Is it a common IT? I mean, so everybody has a different technology for collecting data. we put Vital in place and now that data is accessible, and it's just about accessible to all the providers that, who have a patient there. So trying to sort out how to make that data collection accessible to everyone and making everyone willing to share, I think, because there's a profit to be made if you have a model that, you say, if you do this, you get a little bit more off your premium, you prevent your chronic disease, your blood pressure goes down, whatever it is. And so those are the things that have become very productive for the private carriers. And so for me, it's not rocket science. It's a question about what are the levers that we can put in place that encourage the model to continue and expand the model, but align private and public clinical data collection and treatment. So I don't have an answer. Well, we could put into statute, everybody has to use this IT, but I don't know that that's gonna work.
That hasn't worked in the past.
Hasn't worked in the past.
And make sure you're not stealing each other's payments to make your
Yes,
number of participants goals.
yes.
No,
So,
I think you said it well.
but it's difficult. This is not easy, but it isn't, but it's also something that for the health of the population really should happen. And so,
And I think as we have, when you think about having a cost growth target, and you think about having an affordability index, and you think about the workforce issues, right, as you start to pile these things on top of each other, the fact that we couldn't do 600 and something thousand people in one engine before and then make sure they were assigned to care coordination, perhaps there's a point in time where we could do that, right? And where we could do that because we have to be a cost growth target. And the other options for reducing costs and improving efficiency are, worse from the stakeholders' perspective than getting on board for something like that. And so are we there today? I don't know. But certainly it would be better for Vermont, because of the size of our population and because of the tools we have in place, to be able to make sure that everybody that we've identified as having a need has a support, and that nobody has three of those supports, right?
Yeah.
what would happen if all primary care providers were blueprint providers? Not saying they're in a program, but saying that they are part of a healthcare team. What if we said that? And all of their data for their eligible patients, because we know they've got some ERISA patients, but all of that data goes to blueprint data collection. I mean, what would that do for us, if anything?
So coming at it from the, so we can do the population analysis using VCures and vital data in order to do assignment to the blueprint by primary care, so look at those primary care assignments and the blueprint assignments in real time with the right legislative, you could have someone do all of that. And for sure, like you have authority. So, but I don't know clinically, I'm not qualified clinically to say what would happen.
So yes, we can do that, and we can say, and I don't think you're hearing any disagreement with where you'd want to go with this. I think the issue that's raised by Representative Donahue is how do we get there and not have all sorts of duplication every place else when we get there?
Yeah.
And so I personally perfectly with you to move in that direction, but is there things that we need to do to discourage duplication as we do that?
Well, and I find myself thinking, like, we know where the duplication exists. I mean, like, the groups that are doing care management, Blue Cross Blue Shield does care management, the ACO does care management, you know. Who are the other entities that are doing care management? Like, thinking, like, if you think of it in terms of Venn diagram, where's the overlap, and then who doesn't fit into anyone's care management plan is what your part, I think, what's being talked about. It's like there are those who don't fit into anybody, but then there's others who are duplicated perhaps in multiple places. Is there any way to do that analysis?
I think there is, with the participation of some of the biggest players doing this. If they're willing to participate in specific identification and matching, we could do that Venn diagram. So in other words, if we could get the folks that are being managed by the biggest entities here in the state, the ACO, Blue Cross, MVP, UVM, Dartmouth, like if we could get the biggest players lists, right, we could then push it against a model of who's not in that list.
Might that not be a step that's important in order to understand what we're really looking at?
Yeah, I think that it would be helpful in telling us who's not being served. The challenge is proving the negative there, right? So without pulling in a vendor, an ID and strat vendor, to actually do that at the population level for us as a trial, we'd have all the numbers. We'd know who's being served by everybody, and we'd be able to tell you which ones are duplicated. We wouldn't be able to tell you who's not being, right? So we'd have to run that stratification on the whole population using the VCures and vital data. That's a big deal to run that. I think it's not something that would happen in the time frame we have available.
But statistically, you might be able to assume how many high needs people there are in a population this size. And then after we get all the ones who are, then we end up with sort of a sense of who's not getting anything. Right?
I think there's some stuff our data guy, we can take that back to, and he's going to be working with GMCB, with the VCures data, and so we could kick that around with some of the GMCB data geniuses, right? And I think with Andrew and those folks might be able to figure out something that could give us an idea, but it won't be an individual. It won't be. You understand, right?
Yeah.
It'll be a statistical model, not an actual human model.
So I want to make one reference on the mental health as one of the areas that's referenced here, because we currently have an integration council that's got all of the different stakeholders involved in identifying, among other things, specifically what is the route to go for the best means to integrate mental health in primary care and in the entire healthcare system. So this fits really well with that in one sense, but the language reference that talks about screening for health-related social needs, including mental health, sort of implies that mental health is one of the health-related social needs, rather than the fact that it's a full component of healthcare itself, not an adjunct social need. So I just wanted to note that.
English matters. We'll change the clause
Language
formation there.
Thank you.
So I think I could connect the dots to see health equity implications for this piece. I'm just wondering, let's say we said we want to increase, we want to close the gap for Black maternal care. Can you walk me through how this would help with that kind of effort?
Probably not very well right this moment. So what I can tell you is that when we were thinking about equity here, it wasn't necessarily racial equity in service, but geographic equity and payer equity. So to Senator Lyons' point about if every primary care physician was a blueprint physician, that would promote geographic equity. To the extent that we allow assignment into the blueprint everywhere that there is a blueprint team working with a primary care medical home today, and the key is where they're working with those primary care medical homes. It should not matter today, but I don't have proof that it doesn't matter, your ethnicity right, so, or race.
It depends on who's opted in to be a blueprint practice and whether that is disparate in terms of the population they're serving and that.
Right.
But you have to have one first.
Yeah, so I'm thinking about my district where I know we have blueprint teams working with our various populations, racial and ethnic populations. But I don't know that data is collected that would indicate that.
I just want to share, getting at your question, Senator Ron, is that, so the blueprint also is in certain women's specialty practices. So you asked about women in particular, and also they're in with the Planned Parenthood as part of the Women's Health Initiative. And that's an organization that is very focused on health equity, you may know, and so they serve a disproportionate.
I guess if this is kind of part of like the workforce effort, like, are there other states that, while you're incentivizing people to get into primary care or, mental health care, let's say, or reduce barriers, that have a goal to also increase the diversity of those providers? And is that something that could be built into this?
I see. Provider diversity, not just the patients.
Yeah, I mean, I think whatever our initiative is to tackle workforce, I'd like to see it not to like, you have to have diversity in mental health care providers to actually build equity, to actually achieve equity. You can't, it's kind of part and parcel.
No, that's a great point. We haven't looked directly at workforce in any of these as far as like just improving the total workforce equity. A number of these support workforce broadly, but not specifically to the multicultural workforce and multi-ethnic workforce. Yeah.
But if the workforce working group that just came out with a report, I don't know whether they've dived into that or not. That'd be something to look at.
Yeah.
Where are they? Many working
In the state here.
Okay, is it like
our
healthcare
workforce,
people?
our
Okay.
workforce group report.
Well, that's what I was referring to
Yeah,
earlier.
the Nina Backus came
I
out.
wanted to make a request that.
We should
could
get
that report,
Yeah.
direct the
Yes,
link.
I think what you're talking about is the Director of Healthcare
Yeah.
Strategic
Yes.
Workforce Plan that was submitted to the Green Mountain Care Work. So it does come to the legislature officially.
Right, but maybe someone could
Okay.
make sure.
We can just
each
get it on our
Yeah, get a copy.
Yeah.
I will find it on our website.
Can you do that with also the new health equity grant that's going to the Department of Health? I know Nolan had a link I got earlier.
And then Jen
Right.
sent it to everybody.
Yeah, whatever.
Was it 28 or 29 million?
28.
Yeah,
28.
okay. Well, we could just put those on our webpage.
Yeah, that's the first thing. We'll just send them to Peggy if that's.
Okay.
We can improve the workforce.
Yeah.
Okay,
Have we run this one to ground?
we've run this one. This has been a good one. So what's next?
The next.
Nothing less
for today is PBM.
Oh,
Last but not least.
a simple topic.
So I get to bring you through the last one. We know that prescription drug prices are a big issue across the country. And there has been a lot of work for folks thinking about how to make it more affordable. And obviously this is a big national issue, and a lot of the best solutions are national solutions. But when it comes to states, we had talked about focusing in on pharmacy benefit managers, or PBMs as they're known. As we went to research what was happening in Vermont and across the country, we found that Vermont, actually, you guys have done a lot on PBMs. It might not feel like it's all that you want, but when you look at what you've done compared to other states, really, you have done a lot from a regulatory basis. And you have a current bill pending. I believe it's House Bill 353. And what that bill does is bring together a number of existing statutory language, and also moves to, instead of just registering PBMs, have them be licensed in the state, which would give you some more authority around overseeing what they're doing in Vermont. And the other thing I should say is that there also is, we know, activity happening at the Green Mountain Care Board. They have a pharmacy technical advisory group that's looking at a number of issues. And so as we think about all of the potential things we can work on, we recognize that sort of containing pharmacy cost is important, but we also think it's something that otherwise has some focus, and maybe is not necessarily what you want to spend your time on here, except to sort of bring the spotlight to some of these other activities that are already happening.
So knowing less about that, so apologies there. I was just looking at the Maryland 2019 Prescription Drug Affordability Board Act, and they have a really specific set of criteria for reviewing prescription drugs that either increase in price or come in the market at a very high price, or, you know, generics and brand name. Is that in the?
We sent it to the AG.
It's the Attorney General who reviews those here.
Okay,
Yeah,
A couple of years ago.
we did it.
so that is happening.
Yeah, we did that.
It doesn't mean it's doing anything.
But
Oh, okay.
quite honestly, we're not sure that it's actually doing anything particularly
not-
effective, but we can
doesn't do
believe
anything.
actually on steady.
It's not producing outcomes.
It's,
Does the Attorney General's office send you a report saying, here are those drugs, and
yeah, but you run
now you know?
you run into the fact that they get certain information and don't get certain information, and then they're required to keep it confidential. It's all tied up in all kinds of
Okay.
Red tape.
red tape. You know, wasn't there also, in terms
Trade
of Maryland and the affordable, what they call the prescription drug?
Affordability Board.
Yeah, I mean, we looked at a proposal for that.
Yeah.
Didn't that run into a court challenge, as I remember, Jen?
I think that's maybe a different Maryland, and we're trying to, I think, limit prices on generics or price increases on generics or something. There was something that ended up with an interstate commerce.
Okay, so it wasn't that?
Affordability Board, but there's, I mean, that's one of the many that models that NASHP and other organizations have for states to look at, is the idea of an affordability board. And I think there's a bill, or was a bill in the law, at least in Senate Health and Welfare, maybe also one in House Healthcare, that would put the Vermont Care Board in that role.
Yes.
Sort of leveraging the existing board.
Yeah, we have a bill like that, something about that.
I think, yes, I think you both had them on the wall. I don't think either of them was.
Yeah. So this one seems like, the bill that's in the House would be something to recommend to be evaluated. And
Yeah, and I know that there's been ongoing work on the issue by the sponsor and others on enhancing the bill from last year to bring in more information and background, so.
Right, I just say that I think there was something online yesterday. I wasn't
Yep.
able to tack it into it, but I think Representative Cordes was organizing a presentation around her PBM bill, which is what the bill is being referenced. And it's available online to see. I wasn't able to tune into it yesterday, but I plan to look at it.
Developed by the National Association of Insurance Commissioners. You guys will look at that before we should. The other thing is, I do not know where the negotiation is at the federal level with importation, because we were the first in the country to pass the importation bill. Lost a couple of years ago. I had lost touch since I was in Florida talking about it.
I think there were
Is there anything else?
draft rules or something.
Oh, that's right. They're supposed to draft rules about importing from Canada.
I think there may be, but I'm not sure what else has happened since.
I just recently received a book called China RX, talking about the percentage of drugs that we get from China. I think it's like 85% of our prescription drugs are produced in China.
That's interesting.
And then they go all over the world, but there's no why, if we're getting all those drugs from China, why can't we import drugs from Denmark or Canada or other places? That's a big question, but that's a federal question, is it not?
85%.
A lot.
Oh,
I have to go, yeah.
Everything,
Yes. Okay, so where are we now? Joshua, do we need to talk further about this one?
Only if you want us to do stuff that we're, we've basically said here, I think Beth said it succinctly, that wants on a lot, there's on the wall already. You can target us in other areas.
I think this is not an area where your
Right.
energies are best placed.
The only thing we would do is make a recommendation that the legislature look at the bill.
And so that's it from us for today. Our proposal going forward, sorry.
Is this all you've got?
It's hard to tell if people are sarcastic with mouth.
That's right, that's right. Yeah.
Facial expression.
I'm smiling.
Yeah, I think for
So
you too.
process-wise, we're gonna be digging into data here and answering the questions. And if you do have specific research questions that didn't float up here that are important to you individually, please just hit us with those, send us an email. And I'm certain after this meeting that, next week and the following week, we'll continue some of those stakeholder conversations, importantly with GMCB and Health and Human Services, for the pieces that touch them very directly. And with others as necessary. And then I did mention earlier that we, I have a couple conversations next week with some of the big analytic vendors who may be able to help us envision what we could do on that analytics front that we may not be doing today. So we'll be working on all of those fronts in order to support the information necessary to say, yeah, this is a good idea, or no, let's throw this one out of the bus, right? And I would just remind us all, right, that's part of this process. If we get some analysis at the next meeting, you may say, no, proves we don't want to do this. That's an outcome here too, just as valid as, yes, this is one to continue to push forward.
Yeah, I think the individual household savings are important, but then also the distribution of that based on our groups, ethnic, racial groups will be important. That is one of our charges, so I don't want to lose sight of that. Is there any value, would you value anything more from us at this point in going through the top 7? Or are we?
I think that's up to you. I think we've gotten, we have pages and pages of information from this meeting, and we've been through all 7 of them. So I do feel like we've received the feedback we need to march forward. And as you know, we're gonna meet with you every week, the co-chairs, to make sure we're online and with others as, you know, ad hoc as necessary so that we are sure that we're staying on track as we go. So these meetings are, you know, big 5-hour meetings, but we're doing lots of other meetings in between, including with the staff at JFO and Ledge Council to make sure that we aren't missing something they have in their heads.
So it's going to be really helpful to us to know to what extent the federal government will support one or more of these. The premium question that Representative Lippert is asking about.
Hopefully we'll hear something further as
Yep.
developments hopefully move forward in Washington. But we'll see.
Right, and I guess my priority continues to be primary care and prevention, and to know how expansion of primary care and inclusive of 2 cost-free appointments, primary care appointments for folks. I don't know what that means.
I think I had a similar conversation to at least Bill with Vermont Medical Society about access, and I think I mentioned it to you, you know, just it seemed like they might have a complementary proposal to what we're considering around primary care. Because if we say you have 2 free visits, but they don't have enough primary care doctors, or they're, you know, there's just like, which I thought might be captured in the
There's all of
blueprint.
that.
All these
Yeah.
pieces
Right.
have to fit together.
Yeah, yeah.
And I, you know, I've reviewed their proposal, and you know, it's an ongoing issue that I think we've been committed to.
Right.
Try how to strengthen, the way I would put it is to strengthen primary care.
Right, yes, yeah.
Because there's different aspects to it, and
Yeah.
it's not a single proposal that
Mhm.
is like, you know, some magic bullet, but we
Right,
need to strengthen primary care, and it's everything from workforce. And frankly, a lot of things there are a number of things that we put in motion already
right,
that
exactly.
are on that list.
Yeah.
You know, including support, a lot of workforce initiatives.
Yeah,
We need to look for ongoing sustained funding. We've already actually taken a number of steps, both to try to increase the number of primary care physicians being trained, the number of, you know, nurses, et cetera. So I think there's a lot that's actually underway that's actually listed in some of the proposals as well.
okay,
So,
'cause-
yes, absolutely. And then there's another issue that we sort of talk about once in a while, but that is the link between some of these programs and various administrative agencies or entities. So for example, the Prevention Council that exists within the Department of Health is collecting a lot of, I don't know what they're doing right now because COVID has gotten in the way big time. There's a chief prevention officer in the governor's office. There is a director of trauma-informed services in the Secretary of Human Services office. But so those folks are also doing work behind the scenes that we have not had an opportunity to hear from. We haven't heard from them, but so it might be helpful to know what prevention efforts are going on, because that might preclude the need for some of the care that goes on later on in life. I don't know how to measure that, but anyway.
So
I just wonder, like, if we come out with this report and we really wanted to, you know, spark a conversation in the state, I'm thinking back to Richie's comment about, you know, what's affordability, what's access, and maybe we're saying something like the state needs 75 new primary care physicians, or this what affordability is for a 4-person household, or, I just think that would give people something to talk about, as they look for our proposals. I don't know if we can.
Yes, it's good.
Yeah, like some kind of like,
Comment.
I would like to make sure that's like part of our ongoing conversation, something that wraps the report up and like,
This is
this
what's
is our goal.
This is our goal. This is what's really
This is a
needed.
roadmap to this.
And then the balance between prioritizing specific initiatives that we think are realistic in the sense of, in the bigger picture, among those who are on those committees, what is the realistic opportunities for new funding that might or might not be available in any number of these things. And so how much energy do we want to put into some things or broadcasting things that are
Right.
completely unrealistic to actually achieve
Yeah.
versus what we identify as aspirationally, this is what we should be working towards and
Exactly.
having.
They're saying like, we want a blueprint for mental health that results in X, Y, or Z outcome for people seeking mental health care, that like, you don't have to wait, or you will access it, or it will cost no more than.
So we have urgent care access for mental health like we do for other health conditions,
See?
which we don't have, and therefore people end up in emergency rooms and we wonder why.
Right.
Yeah, I mean,
Continuity of care for people with substance use disorder, so there's recovery centers that are continuous over time, so all of those things, and those, they fit in with the blueprint.
They do, they really do. I mean, my primary concern considers to be those, the discrete groups for whom affordability is a massive issue. Because it's not the population as a whole. And trying to identify them is really hard, but I think we need to focus. And when we do know about them, that's why I keep raising this, the Medicare savings plan eligibility, where we know we have a cliff there that is really hurting people. It's a discrete group. We ought to be targeting things like that.
And then we also know that there's a reimbursement cliff in Medicaid when you have X number of Medicaid patients, your business fails. And so
That's
the
right.
patient loses the
Tied into the cost shift. Yes, right. That we're underfunding Medicaid, and if there's only so much money, is that the highest priority? Right, because we can't do all these things and also address Medicaid rates.
So I'm going to suggest we allow our consultant to take the next steps. Bring back the information to us at our next meeting, which is scheduled for.
What day is our next meeting?
I have to confess, we worked this all out last time, but
November 22nd?
Yes.
Yes.
I remembered it. Okay, November.
10 to, and it's listed as 10 to 3 for that one.
Yes, we're going to meet at 10 on that day. So, and you let us know how we can help you.
And then December 15th is the one after that we're landed on.
So I think that at this point, Mike Farrant, I think, is keeping us on air. We can go offline.